The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Okay, welcome back everyone. We're going to talk about the management of acute chest syndrome in children with sickle cell disease. Limi Children Hospital is actually where we care for children. We have our general pediatrics department, we have the hematology department, we have the cardiology and the neurology department. We actually take care of children from birth to 19 years of age. But right now we're going to talk about the reason why we are here, which is the management of acute chest syndrome in sickle cell disease. So here with me is Dr.
Daniel Uggah.
And I'm Dr. Kanu Akudu, the pediatrician. So
Okay, so we're going to start with an introduction.
Okay, thank you so much. So this is the meat of the day. Our objectives are to, by the time you are done with this webinar, we'll be able to identify what acute chest syndrome is. We'll be able to know the causes, the risk factors. We'll be able to know and implement appropriate treatment intervention when we see these children in our care, and also be able to know how to, reduce the risk factors, the preventive measures, because they are at risk of having recurrent acute chest syndrome. So we want to prevent it to the, basic minimum. So here is a case scenario. We will just briefly talk about this case scenario, and after the discussing the management of acute chest syndrome, we'll be able to go back to the questions that have been, put up to know if we actually, grabbed something and we'll be able to go home with something. So here is a 13-year-old male, known sickle cell, that presented with chest pain, back pain, few days prior to admission, also had cough like 2 days, but developed fever on admission. On examination, general examination, he was actually ill, had heart rate of 140 beats per minute, respiratory rate of 40 cycles per minute, with some saturation in room air was 87%. Then chest examination showed decreased air entry, more on the lower lung zones and crackles. The full blood count that was done on presentation showed white blood cell count of 29.2 thousand, a packed cell volume of 21%, platelet count of 205. The neutrophil was 3%, lymphocyte of 40%, monocyte of 0.6%, and eosinophil of 0.2%. And the hemoglobin quantification test shows HbA of 6.1%, HbA2 of 3.8%, then HbS of 86.5%, and fetal hemoglobin of 3.6%. Chest X-ray done revealed bilateral opacity. So subsequently, I'm going to show some the chest X-rays that were done on admission, few days on admission, and the last X-ray was the one done after discharge during the follow-up review. So this was a chest X-ray on admission, then second day on admission, third day when exchange blood transfusion was done. Then this was on follow-up, the X-ray that was done on review. So the questions here are, what is the diagnosis? What is the differential diagnosis? And what key investigations are we supposed to do? What will be the specific treatment and supportive treatment when you have such encounter with this guest? And how do you follow up the patient? So here is our outline. We're going to talk about we are actually going to talk about the definition by way of introduction. We'll talk about the etiology, how to make a diagnosis based on the history, physical examination, and investigations, and the diagnostic criteria, then treatment, and also we briefly talk about the follow-up treatment. So by way of description or by way of introduction, acute chest syndrome, it's an acute pulmonary complication of sickle cell disease. It's actually an emergency that could be fatal if it could deteriorate and could be fatal if it's not managed properly and promptly. So by way of definition, acute chest syndrome is defined as a new radiodensity on chest imaging accompanied by fever and or respiratory symptoms. It's actually the second most common cause of hospitalization with significant mortality, second to vaso-occlusive pain. So the peak incidence in acute chest syndrome is 2 to 4 years, and it's good to note that acute chest syndrome is directly related to steady state WBC count, that's the white blood cell count. So the more the steady state white blood cell count, the more you have the acute chest syndrome. And it's inversely related to the fetal hemoglobin and anemia. So when there's severe anemia or the PCV is low or the fetal hemoglobin is low, acute chest syndrome gets worse, or there'll be some form of deterioration. So by way of etiology, maybe Dr. Daniel, you take it up from here.
Okay, thank you, my senior colleague. So far, we have spoken about, we introduced the topic, and so now I'm going to talk a little about the etiology and the pathophysiology. So for acute chest syndrome, we know it's a form of vaso-occlusive crisis, like more or less a complication of vaso-occlusive crisis, and there are so many things that could actually trigger a vaso-occlusive crisis. So that's why we are starting with the opening statement that the causes are multifactorial, and sometimes you might not even know what has triggered the of the crisis. So that is sometimes what makes it a bit of a challenge to treat. When you are addressing the clinical manifestation and you don't know what is actually precipitating these reactions, you don't. It takes it's treat you treat it, but it takes a little while longer. But then one of the commonest triggers of acute chest syndrome is infection. So we have, because we know that these individuals are susceptible to infections caused by encapsulated organisms because of the spleen affectation. Sometimes, many times, when they have crises, it affects the spleen, and the spleen is a very important part of the immune system that produces white cells that are able to tackle certain kind of infection. So when this is deficient, you have these organisms, strep pneumonia, chlamydia species, mycoplasma pneumonia, um, really they have an advantage in terms of sickle cell disease to cause infection. They have a predisposition, or the patients have a predisposition to have these infections by these organisms. And then you have other things like parvo B19 virus when there is bone marrow suppression as well. Then pulmonary infarction too. It's another common cause, especially in children, when the microvasculature in the lungs is occluded by the sickle cells. So there is now worsening the oxygenation, making the cells precipitate more, and in the process called polymerization, where the hemoglobin cells they form more chains and cause the cells to sickle and block the vasculature. So pulmonary infarction is another cause. Fat embolism. Well, this is a cause of that's pulmonary infarction as well. But you see it more in older children or even adults when there is when let's say a fat, especially when you have a fracture, then the fat composition of the bone is released into the bloodstream, and then it blocks the vasculature in the lungs, and then thereby causing less oxygenation of the red cells, and then eventual sickling, and you have features of acute chest syndrome. Then preceding history of acute painful episodes. So if a patient has already come and maybe was being managed for vaso-occlusive crisis recently, and it's been on and off, on and off. When we talk about the pathophysiology, we'll see how this can actually lead to a acute chest syndrome scenario, because the ribs, all the but the bony skeleton of the rib cage are all involved in aiding respiration. So when these are affected, you find that ventilation, that's breathing and oxygenating the red blood cells, is not very effective, which can trigger that. Asthma in a similar vein can also lead to this, because it all involves reduced air entry to the lungs, and of course, red cells don't get enough oxygen, and it gets you have a tendency for them to sickle. Post-operative atelectasis. So atelectasis simply means when there is a collapse of the alveoli. So when this has occurred, maybe there is like after surgery, when there is a tendency for, or maybe you have a surgery near the lung region and all, and the nervous system that supplies the lung region, and after the surgery, those pathways are affected. You can have lung collapse, and of course, red cells affectation. Exposure to tobacco smoke, of course, especially in asthma patients, this can actually even trigger an asthmatic episode, and lead to desaturation as well, which can trigger a crisis.
Okay, let me just come in a little bit in the etiology. It's multifactorial, yes, but there could be multiple triggers. Studies don't show that half of individuals with acute chest syndrome have multiple triggers. And it's also worthy to note that children, that the most common etiology is infection. But in adults, it's fat embolism, maybe from avascular necrosis of the head or femur, or from bone marrow necrosis. So what I want to point out here, that it might not necessarily be just one, maybe infection. It could be a multi-triggered event. So remember I said earlier that the peak incidence is between 2 to 4 years. And a prospective study done by National Acute Chest Syndrome study group shows that 50% of individuals with sickle cell will have an episode of acute chest syndrome. And these events occur more during winter or during cold in tropical region, maybe during rainy season and during cold, months. And data from the Cooperative Society of Sickle Cell Disease in the United States shows that incident rates of acute chest syndrome is seen in children with sickle cell, like 25.3 per 100 patients per year has it, and then those with HBSC, 1.95 per 100 patients, per year have it, and then those with beta thalassemia, 3.27 per 100 patients year, could have that. But studies in Nigeria shows that acute chest syndrome in Nigeria, that the prevalence rate is like 5.9% by Sparkle, and the study done in Cameroon shows 6.2% prevalence. So now Dr. Daniel will talk about the pathophysiology.
Thank you. Okay, so for the pathophysiology, we'll try to mention a little bit of the mechanisms that lead to a sequelae of acute chest syndrome when we're talking about the etiology. So, of course, the first thing is just the oxygenation of the red cell, because that is really important. Chest syndrome. Once there's the oxygenation, we have sickling, and we have the other features that are point acute chest syndrome. So, when massive deoxygenation, this occurs when there's hypoventilation. So many things can lead to this hypoventilation, but one of the common things is when if that's why we said in the etiology, when we have recurrent episodes of acute painful crisis, which can be attributed to maybe vaso-occlusive crisis in the spine or in the rib and abdomen. Now, these three components I just told, if you notice one peculiarity about them, you find out that they form the components of the rib cage, which is necessary for inspiration and expiration. And you can, agree with me that if someone is trying to breathe in and breathe out and is feeling pain, there's reluctance to continue that process. And so because of this, there's decreased oxygen getting to these red cells. And of course, as we see, as is highlighted in the slide here, that's the first part of the slide, we can see that massive deoxygenation will now lead to the polymerization of the hemoglobin. So the hemoglobin molecules in the red cells will now join together, they clump together and form large, compounds. And because of these large polymers that are being formed in the red cells, it causes the configuration of the red cell to now change. So normally the red cell is biconcave, but because of this process, it now forms a sickle, just like the sickle that used to harvest crops in the farm. So it forms this sickle and blocks the passage of blood. And as it does that, it's now it's kind of like a chain reaction, because the other red cells too will in turn not get enough oxygen, because that's why the blood is actually even flowing to the lungs to get oxygen so that it can give the rest of the blood. But because the red cells are not even getting oxygen, the hemoglobin in the red cells now start forming their clumps too, and the sickling process continues and it becomes the cascade. So as we've seen, there's now vaso-occlusion, eventually leading to ischemia. So that means the organs and the cells that are supposed to be, perfused, that's supplied by this blood so that they can, get oxygen that is required for their activities. They're now denied of this, and this further worsens the complications of the acute chest syndrome. And then you have endothelial injury as well. So in an endothelial injury, because of this ischemia, you find cytokines can be released, and these cytokines, they trigger release of vascular endothelial molecules, and they trigger inflammation as well. So as this occurs, there is endothelial injury, and then you find increase of a compound called an enzyme called arginase. Now, arginase is an enzyme that um, it acts on arginine. Now, arginine is a compound that is essential for nitric oxide formation. And nitric oxide in itself, it's a potent vasodilator of the blood vessel. So now this nitric oxide now, because arginase activity is increased, there is now competition for arginine, which is required to make the nitric oxide. And because this competition is so high, there is now lesser amount of arginine available for nitric oxide. And that means there is lesser nitric oxide being produced, which will now lead to vasoconstriction. Now, when there is vasoconstriction, this now further worsens the flow pattern, because that means the red cells can't even flow at all. I mean, first of all, the problem was that they occluded the vessel, but now you're now further vasoconstricting them. So they can't really move around, and they can't get oxygenated, leading to worsening sickling as well. Okay, and then use of opioids. So opioids like morphine and other opioids are in that group of medications, group of pain of analgesia. One of the side effects is that they cause hypoventilation. And the thing is that in managing especially vaso-occlusive crisis, we want to reduce pain, and they are very potent analgesic. So, but the tendency to want to now overuse it, or even just using it, would now probably, would definitely bring about the scenario of hypoventilation, because that's one of the side effects. And of course, we can see the cascade of hypoventilation, how it can lead to hypoxia, decreased tidal volume. And once there's decreased tidal volume, that's the amount of air that now gets into the alveoli. You find out that there is now alveolar collapse, and then there is now this ventilation perfusion mismatch, meaning the amount of air getting into the lungs is not sufficient enough to saturate the amount of red cells that are getting to the lungs to get this oxygen to carry to the rest of the body. So other complicating factors include inflammation, that's especially in fever. So fever releases cytokines which can bring about this endothelial injury that we talked about. Fat embolism can occlude the vasculature within the lungs. The pulmonary edema, as inflammation is going on, there is fluid now produced within the alveoli. So that means there's not air and fluid in the alveoli. So that is now not so, because when there's air and there's fluid, they're reducing the amount of air that the alveoli can actually collect and supply to the red cells. And then bronchospasm, like in cases of asthma now, when there is bronchospasm, there is not enough air getting into the alveoli as well. And so this now limits the amount of oxygen that the alveoli can actually supply to the red cells. Okay, so for the diagnosis, one of the very important parts to note is the history, because you might not want to start. Of course, the main thing actually for diagnosis, one of the hallmarks of diagnosis is having an X-ray, but you need to have that index of suspicion. You need to suspect that this is even acute chest syndrome before you start thinking of doing a chest X-ray to rule it out. So the first things first: fever, cough, and respiratory distress. These things, because it's happening in the lungs. So, and we've said one of the common triggers of the acute chest syndrome, of the events, the sequelae of events that lead to acute chest syndrome, is fever, when all those endothelial injury occurs, and inflammation. So you need to, when you see a patient with fever, and then the patient is now coughing as well, and now has features of respiratory distress as evidenced by the alar-nasal flaring, intercostal and subcostal recession. That's, you find that the body is trying as much as possible to assist respiration because respiration is not sufficient. You should start thinking that this might probably, and then there's also a background history of HVSS, so you should start suspecting that. And then another thing also that should be a pointer is when there is acute, this patient also has acute painful episodes, and the symptoms are not even improving despite your treatment. We've been giving some analgesia, we've been trying to treat with, when we talk about treatment, we'll see how we treat it. But then, the symptoms are worsening, maybe there's more hypoxia, the SpO2 is coming down, then you should, have this suspicion that, okay, this is probably tilting towards acute chest syndrome. And then you have other things to look out for, like altered mental status, when there's affectation in the brain, petechial rash, because when there's skin infection, petechial rash as well, wound infection, and the relation to acute chest syndrome. Symptoms of bronchial spasms present or in the past, that this patient has a tendency to have decreased air inflow to the lungs because of this previous history of bronchial spasm. That tendency is there. History of opioid use and fluid overload. Of course, that when you try to, rehydration is very key in maintaining vaso-occlusive crisis, in treating vaso-occlusive crisis. But sometimes we can tend to go overboard, and fluid overload can resolve. And of course, when there's fluid overload, it tends to lead to things like pulmonary edema, and then of course when there's pulmonary edema, the sequelae of ventilation perfusion mismatch can occur again as well. And the history of opioid use, as we already talked about, all these things should be taken note of as well.
Okay, thank you. So we cannot overemphasize on the high index of suspicion in when these guests or patients come to us. They might not actually have fever on presentation, but the progress, if it's not abrupted, it could progress to critical state. So he has already talked about the respiratory distress, looking out for it, because a child can actually present with you, or to you, sorry, with chest pain, spine pain, abdominal pain, limb pain, and has been on admission, being treated for vaso-occlusive crisis, and boom, fever sets in, respiratory distress sets in. So we should have the high index of suspicion when managing guests with sickle cell diseases, and with you should have a high index of suspicion for acute chest syndrome. So we'll talk about the physical examinations, vital signs, and oxygen saturation. We really have to emphasize on that. The heart rate, respiratory rate, is it increasing? Temperature, what is it like? Saturation, is it below 92%? Our target saturation is more than or equal to 95% in room air. So you look out for chest signs, flaring of the LA nasal, dyspneic, use of accessory muscles of respiration. You look out for subcostal recession, intercostal recessions, and all, tracheal tugging and all. So we also look at the hydration status of the patient. We really don't want to overhydrate them. So cautious hydration is indicated in these children. So we look at the hydration status, look at the degree of pallor. Remember, we said earlier that acute chest syndrome is inversely related to anemia. So we look at that and manage appropriately. Then, is there evidence of infection, chest infection? You take, you look out for, evidence of infection, cellulitis, pneumonias, and other things. Then neurologic examination, you check out what is the GCS, what's the mental status, is it altered, is it comatose? Because this could be as a result of hypoxemia, that there's poor perfusion to the brain and all, due to the infarction, pulmonary infarctions. So in investigating these patients, daily food log counts should be done. And before they even come to us, for those that are regular patients, we should have their baseline food blood count. Then when they come down with acute chest syndrome, daily food blood counts should be done. And what are we looking out for? We are looking out for the white blood cell count. We are looking out for the PCV. We are looking out for the reticulocyte count and all that, to compare it with what they presented with, or to be compared with the baseline and institute appropriate treatment. Also, metabolic panel should be done. The liver function test will also be assessed or done to know if there is hepatic dysfunction. Remember that in younger children, they have some form of hepatic infiltrate. And in older children or older patients, they have some form of, kidney dysfunctions. So we look at all those parameters. We also to know if they are, within normal limits, and comparing it with also the baseline. Also, we also look at the lactose dehydrogenase panel to, if it's elevated, then we also institute prompt action. We cannot overemphasize the serial chest X-ray. X-rays are supposed to be done. Even if a patient presents to you without fever, but has this vaso-occlusive crisis and all, we should, especially those on the chest, spine, and abdomen, a chest X-ray should be done. In the previous slides that we put up, on admission, the chest X-ray wasn't so bad, but 24 hours or 2 days into admission, infiltrates all over the place. Pulmonary infections were just all over the chest radiograph. So serial chest X-ray should be done. And it helps us monitor the progress of the disease entity, if we are getting it right or not. Then a septic workup should be done, blood culture. If it's patient on catheter, culture. If there are other sputum culture, if it's cellulitis that is precipitating, whatever, you just, look out for evidence of infection and then, do a septic workup. Continuous pulse oximetry. Every 1 hour, pulse oximeter should be monitored, or the continuous pulse oximetry should be done. Remember, our target is 95% in room air. So we also group and cross-match blood for probable top-up transfusion or exchange blood transfusion, depending on the progress or if the ill health is deteriorating. Another thing we should also look out for is the HB quantification. We'll look at the fetal hemoglobin before and after transfusion or exchange blood transfusion. We look at the HB quantifications to know if we are getting it right, just to help us with the progress of the disease. So this is the criteria for making a diagnosis of acute chest syndrome. It's actually clinically based. So if there is a new radiographic density on chest X-ray, which it could involve a single lobe, it could involve multiple lobes, there could be some complications with pleural effusion, plus or minus, or atelectasis, some of them you could even see that. So when you have a new radiographic density on X-ray, and at least one of the following below, fever greater than 38.5 or greater than or equal to 38.5, then when there is greater than 3% decrease in oxygen saturation, and meanwhile, before that, when our guests come and our patients come, as we are reviewing them, we need to take the, steady state oxygen saturation in room air when they come visiting on outpatient basis, so that we will use that to compare with what they present with in this emergency. Then we look out for tachypnea, because if they have this tachypnea, intercostal retraction, nasal flaring, signs of respiratory distress, cough, chest pain, wheezing, and rales. So number one is that there will be new radiographic density on chest X-ray with any of these parameters below. Remember a high index of suspicion. I keep, putting this up so that we will know that a high index of suspicion should be maintained in patients with chest symptoms and signs, including hypoxia, even in the presence of normal chest X-ray. Even when they present with normal chest X-ray, but they have some form of vascular occlusive crisis, they've been on admission, lying down, not moving and all that, or not ambulatory, high index of suspicion. So treatment should be prompt. We should be proactive. We should have immediate, an active treatment, and also treat the underlying cause. Remember, we said children, they have their etiology is more of infections and other things which could, coexist with it. But we treat the underlying cause and ensure we oxygenate this patient. So specific treatment, we'll talk about hydration status. We maintain adequate hydration. We avoid hydration. Normally, if a child comes with a vaso-occlusive crisis, we keep telling them, drink water, take water, we hydrate at 120% maintenance and all. But when it's acute chest syndrome, cautious hydration should be attained. We don't want to overload them and worsen their problem. So if there is some form of overhydration, when we look out for the signs of overhydration, there is no harm in giving furosemide. We give furosemide to reduce that and help out. Also, pain control. Yes, we have talked about morphine, how it oversedates, how it causes hypoventilation, how it will worsen their problem. Yeah, you can actually do cautious morphine administration to, knock off the pain. Or ketorolac should be used, an NSAID, and it's given at 0.5 milligram per kg and every 6 hours. And we should also be cautious, NSAIDs and their side effects. We are looking out to do serum electrolytes to be sure that their kidneys are also well perfused and not injured. So ketorolac is actually preferred because it has less sedating effect and it has less hypoventilating effect. So this will help us take care of the spine, thoracic, and abdominal pain of VOCs that the guests will have. Also, antibiotic therapy. Children, their major trigger is infection. Now, we have already delineated earlier the organisms responsible. So the antibiotics preferred are the macrolides. We give azithromycin 10 milligram per kg for 5 days in children, and a third generation cephalosporin, the cefotaxime and ceftriaxone. We give that also for 7 to 10 days. The dose is already up there. Also, if it's in older children or in adolescents, although we're not talking about adolescents here, there is also room for fourth generation quinolones. The moxifloxacin has been implicated in used in the treatment in older guests or children and adults. So fever, in the absence of significant build pain, treat fever with paracetamol. So, and then our guest or patient with asthma, wheezing, or positive history of asthma, inhaled or nebulized bronchodilator salbutamol is used, and it's given in scheduled dose to, help with bronchodilatations. Also, in still this patient with history of asthma, wheezing without asthma, or progressive respiratory deterioration, a short course of corticosteroid, dexamethasone, could be used, or steroid. And also it's good to note that once there's some form of clinical improvement, you taper off the steroids. Now, another therapy for immediate treatment is blood transfusion. It could be simple blood transfusion or exchange blood transfusion. And what the blood transfusion does is that it improves the oxygenation and helps appropriately abort the progression of acute chest syndrome. So our aim with exchange blood transfusion is actually to reduce the HbS to 30%, but in top-up transfusion, our aim is to increase the packed cell volume to 30% or the hemoglobin to 10 to 11 gram per dl. We don't want to go above that, because going above that is also worsening their problem. And worsening their problem is from hyperviscosity syndrome. You really don't want to get there, because it could also tilt towards worsening acute chest syndrome and stroke events, acute cerebrovascular accident, and we really don't want to get there. So indication for simple transfusion is oxygen saturation less than 92%. Remember, our target is greater than 95% in room air. So when there is oxygen saturation less than 92%, do a simple transfusion. When the hemoglobin is less than 7 gram per dl, that's PCV of 21, do a top-up transfusion. Then when there is increasing anemia, there's a drop of 10 to 20% of PCV or 2 gram per dl drop of the hemoglobin from the baseline, from the steady state, you top up. Also, when there is decreasing packed cell volume during hospitalization, a top up is indicated. Worsening radiographic changes, impending respiratory, when there is clinical or radiographic progression of the disease, but not impending respiratory failure, because there is another management for impending respiratory failure. So you do a top up. Then also, possibly when there is no adequate blood for exchange blood transfusion, instead of leaving the patient there, you just do a top up while you wait and prepare the patient for exchange blood transfusion. Here are the indications for exchange blood transfusion. Acute chest syndrome is progressing despite your simple top-up transfusion. It is an indication to exchange. Severe hypoxemia is an indication to exchange. Then on the chest x-ray, when there are multilobular diseases, sometimes on x-ray you could see just a segmental, infarction and all. But when there are multilobular, it is an indication to do an exchange blood transfusion. When there is previous history of acute chest syndrome, they are supposed to be on chronic exchange blood transfusion. Then rapid progression of acute chest syndrome or multi-organ failure, hypoxemia, other organs will be involved. Exchange blood transfusion should be done. So progression must be prevented. Remember, high index of suspicion. And then when you're treating, vigilance, prompt and proper, treatment should be done. So how do we know that there are, poor progression of this acute chest syndrome? How do we know? Worsening hypoxia, respiratory rate is increasing, there is decreased platelets count, there is decreased hemoglobin concentration, maybe a child that came with segmental infarction, now the infarct is all over the lung, and then there is neurologic complications. The patient is talking irrationally, patient is comatose, patient is irritable, altered mental status, or indication for, those are the indication for progression. So supportive treatment. Well, I will say I will take oxygen supplementation or oxygen therapy, both as treatment specific and also as supportive treatment. So this could be given as supplemental oxygen when they come. you give direct oxygen. It could be, as a non-invasive, oxygen delivery, our CPAP and our BiPAP, and also we pray it doesn't get to the level when there will be some form of respiratory failure and there will be a need for mechanical ventilation, because that will be the last, treatment for therapy for oxygen. Then what we call incentive spirometry should be done when they are awake, at least 2 hourly. You give them balloons to breathe and blow into it, 10 to 12 breaths. So Dr. Daniel will talk about the differential diagnosis. If you can add more, and how to do it. Thank you.
All right, thank you very much. So that was a very extensive discussion on the management and diagnosis and management. So I'll just talk about things that will mimic these conditions and how we can, the key things to look out for to help us draw the line between acute chest syndromes and manifestations of these other illnesses. So for the first one, acute chest infection. Now, acute chest infection is actually very peculiar in the sense that it does have a tendency to mimic acute chest syndrome. Reason being that for an acute chest infection, especially if it's pneumonia, both of them, you need an X-ray to differentiate the both of them. And you need an X-ray to diagnose, like X-rays, like the gold standard for diagnosing pneumonia. And the same thing too for acute chest infection. But what can help us? Because even in the X-ray findings, you see similar things. Because an infection can even trigger an episode of acute chest syndrome. So you'd see similar things on X-ray. But what will really help us to differentiate this or draw the line between the two is the clinical features. So if it's just an acute chest infection, just an innocent infection that is just affecting the lungs and does not, the hallmark now in acute chest syndrome that the red cells is sickle. That means there's poor saturation and the red cells are sickling and there is sequeling. But in just a pure infection that has not gotten to the point where the saturation of the red cells is not being affected, there's no sickling of the red cells. They are still flowing normally, there's no sickling there. So if you are talking about pathogenesis, that is something to note that is occurring. Now, on the clinical manifestation aspect now, in an acute chest infection, all those rib pains, pain in the abdominal region, all these other the pain, the bone pains that you normally see in vaso-occlusive crisis, you wouldn't normally see it in acute chest infection. They might have dyspnea, but the dyspnea is not now going to be as a result of pain. So I'm just highlighting the fact that it's more of the clinical feature, because if you now use the chest radiograph, you could see opacities in both of them. You could still see your consolidation, depending on whether it's lobar pneumonia or it's multilobar pneumonia. You could still see your homogeneous opacities in both of them. So using the radiological, using the radiograph is not a very good difference. It's not very good. It's not very effective in treating them. Rather, the clinical signs and symptoms that they present with, that's what you actually use and differentiate with differentiate the acute chest infection from the acute chest syndrome. Then pulmonary embolism from deep vein thrombosis. Now, pulmonary embolism from deep vein thrombosis, it normally would start from the dependent area, that is especially the lower limb. So in that lower limb, there should have been a preceding history of maybe leg pain, swelling, discoloration of the point where it started, where the pain started. So if there's a preceding history like this, you could actually now, have a high index of suspicion that, oh, okay, this chest signs that you're seeing was actually something that must have been triggered by a deep vein thrombosis. Of course, you know that when deep vein thrombosis gets complicated, it could lead to acute chest syndrome. But now, the one clinical sign that is very useful in differentiating the two is that in pulmonary embolism from deep vein thrombosis, the chest pain is normally sudden. All of the sudden, as in, they just have a sudden chest pain and it's acute, and they start decompensating very fast. If not, if care is not taken, it can even rapidly progress to, fatal state. What's in the acute chest syndrome, it's not, it doesn't usually follow such a sudden onset. Very rarely will you find the deterioration so sudden and rapid compared to pulmonary embolism from deep introduces. Normally it's progressive because there is sickling, there is poor saturation and all that. So it's a progressive pathway. So but to differentiate them normal, because as I said, in pulmonary embolism, normally the chest pain is sudden. And then there is also a preceding history of maybe leg pain, swelling, discoloration of the feet, and all those other conditions. And then of course on the acute chest syndrome side, if you've been having repeated or recent frequent episodes of pain crisis, and other clinical features associated with sickle cell anemia, you know that okay, this is tending towards acute chest syndrome. Then acute severe asthma. Now for acute severe asthma, you know that it's also the clinical features that are actually very useful in differentiating if the chest symptoms they are finding is as a result of an asthmatic reaction, which is due to exaggerated response of the immune system, or if it's due to acute chest syndrome. Now, how do you know this is if maybe there was recent exposure to cold, and there's also family history of the asthma. That's if the asthma is not diagnosed and you don't know if the patient is asthmatic, or even if you know, say it's even a useful pointer to say, okay, maybe this is just acute severe asthma. And of course, if there are no associated bone crisis that pain crisis, of course, the pain is in the bone. Pain crisis that occurred prior, you would actually have a hint that okay, this is probably and acute, this is probably acute severe asthma. Of course, you know that if it's acute chest syndrome, you have more of the complaints of okay, recently the patient has been managing some bone pain, frequent pain, and pain when trying to breathe as well. Then in another thing, sorry, let me go back to the pulmonary embolism. There is normally shortness of breath. This shortness of breath is because the both of them really are shortness of breath, but you see more in things like pulmonary embolism because and pulmonary embolism, pulmonary edema, because the fluid tends to accumulate in the lungs, and the patient now tries to breathe faster to try and make up for the deficit of the volume of air that is in the alveoli. So they have to now try and breathe faster to try and inhale, expel, the carbon dioxide, inhale the oxygen, so that the volume of air they're getting overall can try and meet up with what the body needs. So that's shallow breathing. That means they tend to want to just get more oxygen, so they are trying to breathe faster. And it's not so deep, just breathe in, breathe out, breathe in, breathe out. But ideally, the expiration should have been longer than the inspiration. Okay, so in severe vaso-occlusive crisis, of course, if you know that this patient is being managed for pain crisis, vaso-occlusive crisis recently, you know that there are so many things that could have gone on. So your tendency will be tilting towards acute chest syndrome because the person is exposed to a myriad of risk factors. First of all, if we are using opioids, voraciously, or just try to control the pain to the point that it has started causing hypoventilation, you know that, oh, okay, this is a possibility. If you are trying to, because you are trying to reduce the hyperviscosity and hydrating, as has been said earlier, normally you would want to do 120% maintenance, but because of fluid overload, you want to reduce 100% maintenance. So my point is that there is a tendency to overhydrate, and when you overhydrate, of course, you know that sequelae of pulmonary edema. So you know that okay, this is probably tending towards a vaso-occlusive crisis that has occurred in the chest region. So that means there is poor saturation of the rest of the in the chest region. So you'll be thinking towards acute chest syndrome as well. And so the pain crisis, the hypoventilation, and then of course when we're talking about the two pathogens, we talked about pain in the rib region, the abdomen, the spine. So if you've had a vaso-occlusive crisis, there's also a tendency that there's vaso-occlusive crisis in this region. So breathing, the patient will be reluctant to breathe in, breathe out because of the pain associated in those areas. The ribs have to move in and breathing out. So you'll be tending towards thinking that, oh, okay, so maybe there's now hypoventilation, so you'll be thinking towards acute chest syndrome. So these are some of the ways. So I can summarize it by saying if you are getting something to, because acute chest syndrome really is a complication of vaso-occlusive crisis really. But the vaso-occlusive crisis now happening in the chest region. So if you are having things pointing towards vaso-occlusive crisis, pain crisis, more that is what is more in the picture. Then you're thinking towards, okay, this is acute chest syndrome. But if this episodes of vaso-occlusive crisis or things that are pointing in that direction are not there, you're just having more, maybe wheezing, difficulty breathing, shortness of breath, fever, but you're not having all these pain crisis, vaso-occlusive crisis, then you're thinking towards all these other differential diagnoses. However, it's not impossible to have, the sequelae of acute chest syndrome without, pain crisis as well. So it's not, but these things are pointers that can help. And then, of course, if you now want to go ahead, if the patient is undiagnosed for asthma, you want to do a peak flow, you want to use a peak flow meter to diagnose that. For pulmonary embolism, gold standard is okay.
Okay. Thank you, Dr. Daniel. So, honestly, you said that acute chest infection cannot really be, differentiated. Yes, pneumonias. Remember the diagnostic criteria that I gave earlier on? They all fit into pneumonias. They all fit into the criteria for pneumonia. So you can't categorically distinguish the two of them, both radiologically and clinically, because they all look alike. Then the pulmonary embolism, there will be some form of, history, previous history of, maybe family history or history of some leg swelling or dilatation of the vessels of the leg and all that. So yes, varicoses. And then acute chest severe asthma, there is history. There'll be a family history of acute severe asthma in the patient or guest. That doesn't mean that sickle cell patients don't have asthma. I've had a lot of, not quite a number of, patients with sickle cell and asthma coexisting. Yes. Then severe vaso-occlusive crisis. When the pain score is greater than 9 or equal to 9/10, then maybe rib infarction, maybe possible, even it could mimic even rib fracture. So when you do a chest x-ray, you will see maybe a rib fracture, but that pulmonary infiltrate will not be evident in severe vaso-occlusive crisis. So it's actually just bone infarction or, vaso-occlusive crisis. And once you give the analgesia and hydrate and treat the cause, and they're home and dry. Okay, long-term complications, recurrent and acute chest syndrome can reoccur. 50% of individuals have been found to have recurrent, or 50% of individuals with sickle cell have been found to have recurrent acute chest syndrome. And it could also lead to what you used to call a chronic sickle cell lung disease. It is now called the interstitial lung disease. It could also, precipitate to pulmonary hypertension and, death at last, or risk of death. So you're going to talk about the follow-up and the preventive measures. Before discharge, we ensure that they are on incentive spirometry and that they are ambulatory. Once their pain is being knocked off, you allow them to walk around. You allow them to walk around and ambulate while on admission. Then we ensure that their saturation is greater than 95% before on discharge. So survivors are followed up for a long time with the goal of preventing reoccurrence, and we monitor them for a very long time to, keep them healthy and, give them good quality of life. So in preventing this reoccurrence, first of all, we prevent the infection. And this is achieved by giving appropriate childhood immunization, which includes pneumococcal vaccines, even those less than 5 years. Some, school of thought will say less than 7 years, you place them on oral penicillin V. We know the reason why we do that. Then pulmonary function test is being done every 2 to 3 years. Some school of thought will say for patients with asthma, do the pulmonary function test every 2 to 3 years, but those without asthma should be done 5 yearly. But we do 2 to 3 years pulmonary function test so that we know when there is problem or an impending problem. Also, this polysomnography, that's doing the chest x-ray on rest, periodic oximetry should also be done, even with those that have had acute chest syndrome with asthma or without asthma, and it should be done. Bronchial spasm should be dictated and treated early with bronchodilators. So these dilators, we are talking about those individuals with asthma. Then we'll try and ensure that the triggers, they stay off or stay away from the triggers. We detect and treat pulmonary hypertension. We also use disease-modifying therapies. We use hydroxyurea to reduce the risk of sickling and the frequency of acute chest syndrome. How do we get this done? Hydroxyurea increases the fetal hemoglobin, which has a lot of affinity or more affinity for oxygen. And this, prevents them from having frequent crises, frequent vaso-occlusive crisis, and frequent hospital visits and all. So if hydroxyurea fails, chronic transfusion should be instituted. And this chronic transfusion, we have two types. We have the short term and the long term. Short term is given for 6 months. Long term is given for more than 6 months. And this is exchange blood transfusion, which is done within 4 to 6 weekly. So those that get the, short-term chronic transfusion are guests or patients, sickle cell patients with 2 episodes or 2 events of acute chest syndrome in 24 months. But those that has had more than 2 episodes, we, institute a long-term chronic transfusion. So for multiple acute chest syndrome, some school of thought will say more than 2, hematopoietic stem transplant is recommended. Although there are other medications, the L-glutamine, the critisilab or something, the P-selectin medications, and the voxelotor can also be used. But these medications, what they do, they prevent acute painful crisis. Their efficacy in acute chest syndrome has not been, affirmed and all. So thank you so much for your time and thanks for listening. And now I'm going to introduce my friend to give us brief. Okay. Here. Is that all? Okay, before we take our questions, I've actually seen all our questions, but my Dr. Pamela is coming to give us a very brief talk.
Can you see my screen?
Yes, I can.
Good evening, everyone. My name is Pamela Albai, Head Corporate Relations, Limi Hospital Group. I'm just going to give a brief intro about the Limi Children Hospital, how we can be reached, how you can refer, and the collaboration opportunities available with the Limit Children Hospital. Limit Children Hospital is an arm of the Limit Hospital Group, as you already know. We are located at number 39 Ademola Tokumbo, Wuse to Abuja. It is a designated specialty hospital for pediatrics, neonatology, and general medical care for children. What are we known for? We are premier private pediatric hospital in the heart of Abuja, foremost private pediatric referral center serving up north central Nigeria, leveraging on over 40 years experience under the Limit Hospital auspice. A group of healthcare workers determined to change the Nigerian newborn and child healthcare indices for better. What do? We deliver excellent pediatric care with obvious guest delight. We facilitate the happiness of families through great healthcare delivery, and we offer comprehensive child health and pediatric services. Okay, so here are a few of our services. We offer our core areas of services are pediatric cardiology, neurology, developmental pediatrics, neonatology, surgery, hematology, and etc. Our newborn services include care for extra time, with heart success rate of 26 weeks. We've also had 25 weeks at the Limit Children Hospital. We have transport medical services, surfactant administration, mechanical ventilation, neonatal cardiac services, and a standby neonatology team for emergency. Other activities at the Limit Children Hospital for training. We have monthly webinars, which is the one we are currently having now. We also run monthly hospital presentation at the pediatric department around the hospitals in Abuja environment. We also have the two-way referral services. It means when you refer to us, we send a detailed feedback referral report on management, treatment, and everything that we did for your patients while sending them back to you. We're also open for research and collaborations. We have some MOU already signed with some teaching hospitals around the western region of Nigeria. How to refer patients and the numbers you can reach. You can give a standard referral letter, preferably attached to the referral form. You can also call any of the numbers on the screen, or you reach us on WhatsApp. You can also email us at limitchildrenhospital@gmail.com, or you visit number 39 Ademola de Tokumbo Crescent, Wuse to Abuja. But please, while you're at it, kindly indicate your name, your email, your phone number on the referral form, or while you're referring through online, so we can, link you up with the managing team, the managing expert. Maybe there are some questions or collaborative efforts that we might need from the referring doctor. If you have your details, it will be easy to collaborate faster. And then to also appreciate at the end of the year. Our next step include pediatric interventional cardiology, which is coming up shortly. In collaboration with our cardio care branch, we will be focusing on structural heart defects for ASD, VSD, for children presenting with congenital heart diseases. And why consider Limit Children Hospital as a referral center? Like I mentioned earlier, team of consultants stand by in all medical specialties for children, detailed feedback referral in form of a medical report to referring doctors or facilities. Opportunity to discuss and collaborate with a team of unreferred cases, like I mentioned. 24/7 emergency services. So wherever, whenever, most especially for children that are born preterm, we have the facility to move them from the place of birth to the facility where they can be managed. That's what I mentioned earlier about transport incubator, comprehensive neonatal care and management, ultramodern world-class equipment, and fully computerized system. We also have the medical hub, social media, WhatsApp platform where we can share cases, share ideas, and you can also get notification about our upcoming webinars, about our upcoming programs, how to also refer. You can also reach.
The Limit Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limitchildren.org.